Thanks everyone for joining us and Happy New Year. We are delighted to kick off the new year with a great speaker. It's Jocelyn Jiao. Dr. Jiao is actually double board certified in both neurology and in palliative care, which is a rare combination to have. And we're so lucky to have her at Stanford. And she has been at Stanford for a few months now, and she's in movement disorders and in palliative care both, and she'll talk about a little bit about that, I'm sure. And the main focus of her talk today is on caring for the whole person in Parkinson's disease, and she'll describe what that is and what palliative care is. And if you have questions, please use the Q&A box. At this time, we're trying to figure out how to get the chat enabled, and we'll keep working on that. And if you have any questions, go ahead and put them into the Q&A box, and we have lots of time at the end to ask questions and have them answered. Okay, so take it away, Dr. Jiao.
Thank you, Robin. Thank you so much for inviting me to speak today. And thank you to all of you for joining me here today. My name is Dr. Jocelyn Jiao. I am like Robin said, palliative care doctor at Stanford, and I'm one of the movement disorders neurologists there. That all makes me especially glad and honored to be speaking with this group. The title for today's talk, as Robin said, will be Caring for the Whole Person in Parkinson's Disease. When we about living our best life, I imagine that many of us think of scenes similar to those pictured here. Being surrounded by friends and family, enjoying good food, enjoying pizza particularly, being active, being outdoors, hiking, spending time with our children, or our parents or our families. Some other things not pictured here might include participating in our church, our faith communities, caring for loved ones, caring for pets, and contributing in our jobs or work. These are all things that joy and meaning to our lives. As a doctor, I see that unfortunately for some people, illness can get in the way of their best lives. Illness can create challenges that make it difficult for us to access joy, meaning, or purpose. Challenges can be physical, they can be psychological and emotional, political, financial, even existential and spiritual. I'm here to talk about how we can recapture some of that quality of life, that joy, connection, and meaning, even when living with a difficult illness like Parkinson's disease. Over the course of the next 25 minutes, we will talk about an approach in medical specialty that focuses on making life as good as it can be. Along the way, I want to make sure if I clarify anything, please put it in an A. But like Robin said, we will have a lot of time at the end to answer any questions that arise. I'll do my best to address any clarifications as they come up. Today, we will cover the following topics. What palliative care? How is palliative care different from other parts of medicine? When and how can someone benefit from palliative care? How does palliative care help people live their best life? And the difference between palliative care and hospice. So what is palliative care? To get us started, I'd like you all to think about what comes to your mind when you hear that term palliative care. I would say, think about it. You can even write it down on a piece of paper next to you. I'm sure that many people will think of many different things that come up. I'd like to start off this talk by talking about what makes palliative care different from other medical teams. Firstly, in palliative care, we start with the perspective that we center our attention upon the person beyond the disease. We emphasize the individuality of every person we work with. This isn't to say your other doctors don't do this, but this is our focus. How do we do that? Palliative care takes a holistic approach to care. We think of the person and those close to them as the center of that unit. That includes family, care partners, and guardians. We all see them as part of that central unit. We also acknowledge that when someone is living with a serious illness, that there's more than just the physical symptoms. There's more than just the body that can suffer. We know that the body, mind, spirit, and practical aspects of life can all be affected by illness. So, unlike a cardiologist who focuses on the heart or a neurologist who focuses on the brain, we don't just focus on a single organ or illness. We focus on the person and all the aspects of life that are affected. To make sure we address all the components of life that can be affected by a serious illness, we work together as a team. In fact, if you see a palliative care team, often you will meet one or more of these members during the visits at the same time. The doctors and nurses focus on managing bothersome symptoms and prescribing medications. We also help patients and families with medical decisions and advanced healthcare planning. We can also help coordinate with the other doctors on your care team. Social workers can provide emotional support through regular phone calls, video visits, or check-ins. Social work can provide caregiver support to your loved ones, help people get medical equipment, talk about financial concerns, and look for assistance if possible. Chaplains provide spiritual support. Yes, they can offer prayers and blessings. They can also help people face some big existential questions, such as, why is this happening to me? Or how do I find meaning now that my life is so different? Chaplains can be incredibly effective at addressing those big existential concerns, regardless of a person's religious or spiritual background. So far, we focused on how palliative care is different from other specialties, and I want to go ahead and provide a commonly accepted definition to dig in a little deeper. Oh, let's see, my screen disappeared. Everyone else can see it though. That's interesting. Give me 1 second. There we go. Palliative care is specialized healthcare for people living with a serious illness. This type of care is focused on providing relief from the symptoms and the stress of the illness. The goal is to provide quality of life for both the patient and family. Palliative care is provided by a specially trained team. Palliative specialists work together with a patient's other doctors to provide an extra and essential layer of support. Palliative care is based on the needs of the patient, not the prognosis. It is appropriate at any stage and at any point in a serious illness and can be delivered alongside curative treatment. One of the first components of that definition is the idea that palliative care is for people living with a serious illness. First off, I would say that any illness that has any possibility of reasonably being life-limiting over the course of years would be appropriate for palliative care. Some of the examples of illness and conditions that we commonly see include cancer, heart failure, Parkinson's disease, dementia, and ALS. I would also add that there are many other diagnoses not listed here, and there are cases where the particular diagnosis is less important, but the person's care needs help us recognize that we can be helpful with their care. In terms of the services we provide, one of the main ways we can help is to manage any symptoms that are keeping your life from being as good as it can be. Some of the most common symptoms we work on in Parkinson's disease include physical symptoms like pain, constipation, muscle spasms, increased saliva, as well as psychological symptoms such as agitation, anxiety, depression, and larger, harder to define problems such as coping with illness, fatigue, loss of appetite. We're here to help caregivers and family members who may be experiencing their own distress. So how do we relieve symptoms? As I mentioned before, we take a holistic or whole person approach, and that applies to managing symptoms. Let's use insomnia or difficulty sleeping as an example. Let's say I'm seeing someone in clinic who has Parkinson's disease, and they're telling me their sleep is getting worse. This difficulty sleeping, it might be related to their brain sending stay awake signals to their body, but it may also be related to their increasing worry about paying for more caregiving. It might be a side effect of their antidepressant. It might be related to not being able to find a comfortable position while sleeping due to their back pain. My patient may be so sleepy during the day that they can't go to their grandchild's birthday party the next day. It may cause them to feel more socially isolated from the people close to them. And when they're staying up at night, they may begin to wonder if the disease and everything they're experiencing is a form of punishment from God. To address people's health as a totality, what we call total health, we have to consider what's happening in someone's body and also address how that symptom is affecting their life. So, our tools include medicines, yes, as well as psychological interventions, integrative techniques such as acupuncture and mindfulness, in addressing spiritual and existential concerns. In addition to helping manage symptoms, we help with making medical decisions. This can include things like advanced healthcare planning, which is an umbrella term that includes conversations about people's wishes. We can also help people complete documents like advanced directives or post forms. We can also help with weighing treatment options. This can include things like helping someone think through whether they want a feeding tube, helping someone decide, is it time for them to transition from home to a facility? Helping families prioritize what's most important in their loved one's medical care when time is looking short. As some of you likely know, making medical decisions can be hard. Making medical decisions in Parkinson's disease, where there can be so much uncertainty about the future. When multiple people in the family can have different perspectives on what's helpful or not, that can all make it even challenging. And this is honestly my favorite part of the job, helping people weigh the benefits and burdens of treatment options within the context of what's important to them as individuals. Palliative care is here when you and your healthcare team need it. And that means at any age, at any stage. There's no particular age, diagnosis, prognosis, or treatment plan that makes you eligible or ineligible for palliative care. And it is extremely important to know that we can be helpful anywhere along your journey with Parkinson's. In a typical clinic day, I see patients who've been newly diagnosed with a new illness, patients who are pursuing treatment, patients who are engaged with clinical trials, and patients who are also working to live, to thrive with their illness, and they're not receiving any treatment targeting their underlying illness. Among palliative care circles, a common saying is that if our services were a pill, we would be the next big blockbuster drug. Part of this comes from the landmark study published in the New England Journal of Medicine. This study showed that patients with newly diagnosed advanced lung cancer actually had a survival benefit when they received consistent monthly outpatient palliative care visits. Patients who got palliative care lived an average of 3 months longer than those who did not receive palliative. Across many studies of patients with many different diagnoses, palliative care has demonstrated consistent benefits for patients and families, including improved quality of life, lower symptom burden, improved spiritual well-being, improved psychological symptoms, and improved satisfaction with care. Many of these studies have also shown that people engaging with palliative care spend less time in the hospital. They have fewer hospitalizations, fewer hospital days, and there's less burden on caregivers. The number of studies looking at palliative care in neurological disease is growing, and the evidence is just as compelling. This study looked at people living with Parkinson's disease and separated patients and caregivers into 2 groups. One group, the orange dots, in which patients and caregivers received standard care. One group, the black dots, in which the patients and caregivers had integrated outpatient palliative care. Each group was studied over 1 year, which is the horizontal axis on these graphs. On the left side, the y-axis, you can see on the left graph, the black dots, the people who received palliative care scored higher on a quality of life survey. So a higher score, a higher dot on the y-axis is a higher quality of life. On the right graph, this is a survey that measures caregiver burden. This is the ZBI. The higher the score, the higher the caregiver burden. The black dots, the caregiver palliative care group, had less caregiving burden at 1 year of the study compared to the orange dots, the caregivers who received standard care. Many people wonder, when should I ask for a referral to see a palliative care team? I would say if you're living with a serious illness like Parkinson's disease, palliative care could be right for you. We can be especially helpful if you're having difficulty with symptoms, difficulty with decisions, or difficulty coping. Our team is also particularly helpful if you feel that multiple aspects of life are becoming difficult and that your illness is affecting your mind, your body, and spirit. Many people are, if palliative care is expensive, and who pays for it? Palliative care is covered by insurance like any other specialist someone is seeing. For example, it's just like seeing your neurologist in clinic or an oncologist. Access to palliative care has been improving statewide ever since some initiatives have helped increase access to palliative care, requiring that some people with certain diagnoses who are covered by public health insurance have some way of accessing palliative care. So, how can you access palliative care? The first step is to ask for a referral from a primary care provider or from a primary specialist like your neurologist. Inpatient or hospital-based teams, including the emergency room, can also make a referral depending on your insurance plan. I wanted to address a very common question that people ask me when they first meet me in clinic. First and foremost, palliative care and hospice are not synonymous, though I will advise you that many people, including many well-educated healthcare providers, may conflate and confuse these terms. So I'm glad you're all here to help me get this correct. As we have described already, palliative care is a large and broad field focused on symptom management and helping make sure that the care plans focus on what matters most to people. Again, palliative care is here for patients of any age at any stage and can be evolved in addition to curative treatment. Hospice is a small part of that type of care that palliative care providers are trained in. It's only a part of what we provide as a field. So what is hospice? Hospice care can be a little confusing because the term really refers to several different things. First and foremost, hospice is often used to describe a philosophy of care. On a practical side, it's also a health insurance benefit that is included in all insurances. From a practical side as well, hospice is a set of services that can be provided in any setting, a home, a facility, or a hospital. As a philosophy of care, hospice focuses on supporting patients for whom comfort and quality of life is the highest priority. In providing this type of care, hospice typically asks and thinks about every intervention, every lab test medicine, and asks, does this help make the person feel more comfortable? If it does, hospice will try to do that thing and make it happen. If it does not, hospice will recommend stopping that or deferring it. Again, the philosophy of hospice care is a really good fit for people who want quality of life and comfort to be their number one priority. That often means less focus on pursuing interventions that might prolong life. As a philosophy, hospice also aims to support people being in the place that is most comfortable for them. For many people, that happens to be in the home. So hospice does everything they can to make people as comfortable as possible while keeping them in the home. And typically that means avoiding going to the hospital. For some people, being in the home is not what is desired, and hospice services can be provided in nursing homes or even in specialized hospice facilities or hospice houses. As an insurance benefit, hospice services are covered under every insurance plan. There are regulations and guidelines that hospices must follow. Medicare provides a guideline that patients should have a 6-month or less estimated prognosis to be eligible to receive hospice benefits. The philosophy, again, hospice is to provide comfort-focused care. Therefore, hospice may or may not pay for certain treatments that do not provide more comfort. There is more and more variability in what certain hospice agencies will cover and allow under their care. Talking with hospice agencies about individual cases is always helpful, as unique situations happen frequently and everyone's circumstances are different. Hospice through the insurance benefit is typically delivered by a provider, an agency like Mission Hospice, Pathways, VITA. Those are just a few examples. This is an information packed slide that summarizes some of the services, and I'll emphasize just a few points. Hospices are composed of an interdisciplinary team similar to a palliative care team. So that includes doctors, a nurse case manager, a social worker, chaplain, volunteer, and home health aides. As mentioned before, hospice is not a place. The service can be delivered and received in the home, in nursing homes, and in a specialized hospice house in some cases. One benefit of hospice is that it provides you access to a 24-hour phone line that is staffed by a nurse. This nurse can help give advice about how to help symptoms with the medications you have at home. If your needs are more than what the hospice nurse can manage over the phone, hospices have the ability to send a nurse out even to see you. Hospice also takes responsibility for prescribed medications needed for symptom relief. They also prescribe and provide medical equipment, and that includes a hospital bed, commode, or wheelchair. As we start to wrap up, let's talk about local resources. We're very lucky here in the Bay Area to have a lot of great palliative care programs. This is a map of some of the programs who are around in the Bay Area. This is certainly not a comprehensive list. I put this up to show that we have good coverage, including private, public, and safety net systems. The best way to find a palliative care near you is to visit getpalliativecare.org and search your zip code, or ask your neurologist for a referral. There are online resources out there that can provide you some more information on palliative care and its approach. This is just a short list, and certainly you will have the slides from this talk available for you to use at your leisure. As a take-home message from today, I hope that you will remember that if you feel you are on a difficult journey, palliative care is here to partner with you, to help you, your family, and your neurologist to carry that load, to improve quality of life, and to navigate difficult decisions. I wanted to put a slide here, especially being a dual appointed neuropalliative provider at Stanford. I have a particular clinic and a particular resource in mind to share your group. Stanford Neuropalliative Clinic has been ongoing for a momentous few months, ever since I started. It is an interdisciplinary specialist palliative care program for people living with neurological disease. So certainly I see all comers in terms of diagnoses, but also especially this clinic serves people living with neurological disease, and Parkinson's disease is a big one. I have virtual and in-person visits available to accommodate people, to make sure that everyone has access to this special resource as possible. It is available to all people who are engaged with the Stanford healthcare system. There is a particular way to be referred to me. Any provider can place the referral. The referral out to palliative medicine, and to make sure you are interested in seeing me, to see if you write for neuropalliative care or my name, that usually is a signal and a trigger to the process to have that person scheduled with me versus another provider. Like I said before, referrals can be placed by any provider. That includes your primary care doctor, includes your neurologist, who has access to our healthcare system. Thank you for all of your kind attention, and I'm happy to take some questions for the remaining minutes.
Awesome. Thanks very much, Dr. Jiao. Okay, I have a few questions. Our resident social worker is rapid fire sending us questions.
Great.
Said, well,
Amazing.
this is fantastic. It sounds like it's a really good idea to concurrently receive palliative care and neurological care, which she totally supports. Could you please give us a thumbnail sketch about how you proceed with patients? How often do you see them? How patients access you when in need?
That's such a great question. The best way to be connected to me to begin with is through that referral process I mentioned. So any kind of referring provider can essentially connect you to a palliative care team or a neuropalliative care provider like myself. One meet an individual and their family, their care partners, the people around them, essentially how often we see each other depends on what the needs of that person and that family are. I covered, we do a lot of different kinds of things. We prescribe medications, but we also talk about big medical decisions and what to expect for the future. So for many people, the tempo at which I see them kind of depends on is arising. What are the ways in which our team can be supportive and helpful? As a rule of thumb, I try to check in with people at least every 1 to 2 months when they are part of my panel, if only because the time that they're usually seeing me, I wish it weren't necessarily this way, but by the time they meet, a big there's an amount of suffering and distress that needs to be untangled and explored. So often I try to keep a pretty close eye on people and to touch in rather frequently. I know that as a movement disorders neurologist, I wish I could see people that often. That's obviously not the case, as all of you may have experienced. But in my palliative care role and my neuropalliative care hat on, I have the flexibility, and many palliative care doctors have this as well, to check in with you more frequently because that's what they're there for. They're there to make sure you feel supported, and often having frequent touch points is great for that.
And can that check-in be phone, email, in person?
Yes. So the interesting thing about palliative care, especially during the pandemic, is that the field was revolutionized by the ubiquitous nature of televisits. So the vast majority of the palliative care visits that palliative medicine at Stanford does are virtual. I would say probably 90%. That is not the case for every palliative care program out there, but one of the main reasons that the Stanford Palliative Medicine Group feels so strongly about having virtual options is that patients love them. um,
Yeah.
for my patients who want to come see me, there certainly is always in-person availability. I'm sitting there in the clinic on the clinic computer, so if someone wanted to come in and have a face-to-face to establish that bond and that trust, we really encourage that. But it's all based on meeting people where they are. So either is possible.
And the latter part of the question was how can patients access you when in need? So if they're already
Mm,
receiving services from you, how do they tell you I need your help now?
yeah. Much like any kind of other outpatient clinic, either calling in or sending my health message or contacting people through whatever kind of patient portal exists is the best way to get in touch with their palliative care team.
Okay. I have another question. Do you take care of people with young onset Parkinson's? I have young onset Parkinson's and I'm 37.
That is such a great question, and I'm so glad that you asked that, Lisa. So yes, absolutely. There's no particular age that people need to be at to qualify for palliative care. So we see people of all ages, adults of all ages, I should be more specific. Um, Anyone who has essentially a serious illness can access palliative care.
Okay. I was interested in the two charts that you showed, the one showing that uh, people with a diagnosis have a better quality of life and that the
Mm-hmm.
caregivers have a lower caregiver burden, both of
Mm-hmm.
which
Mm-hmm.
obviously are good things. And that was over a
Mm-hmm.
year time, which is fantastic.
Mm-hmm.
What disorder was that with, and do you think that makes
That
any
was
difference?
Parkinson's
Oh,
disease.
that was
Yeah,
PD.
that
Oh, that's
Parkinson's.
fantastic. Yeah,
Mm-hmm.
yeah.
Yes, it's a
Uh,
really wonderful study. Oh, go ahead.
no, I was just going to say that it's fantastic that that
Yeah.
such a study was done.
The big leaders in the neuropalliative field completed that study, and UCSF, I believe, was one of the centers, as well as the University of Colorado and another institute on the East Coast, all participated in that multi-center controlled randomized study. So it's
Hmm.
really an amazing So much of what I'm talking about is built upon um, the hard work of all these people who led those studies. And Dr. Maya Katz, who's one of the Stanford movement disorders neurologists, she was also one of the leaders in that study. She's been a huge support of palliative care for people living with Parkinson's
Yeah,
disease.
we're very lucky to have her here as well. Um,
Hmm.
one of your slides mentioned some of the reasons to consider palliative care if it's
Hmm.
a serious illness, if there are challenging symptoms. And one of the other items I think on that slide was difficult decisions. Could you give some
Hmm.
examples of what those difficult decisions could be?
Absolutely. Often, I think decision making in the medical context is very complicated. And I think sometimes having trained in the medical field, have been a doctor for some amount of time now, um, I think being on the provider side, one forgets how complicated those decisions can be at times for people. So people can I've guided and talked to many families who are encountering all sorts of different kinds of decisions where they have to weigh sometimes competing interests or competing values. And that there's always a pros and a cons list to whatever decision you're taking on, even if it's something like starting carbidopa levodopa, right? Like that decision can be a big deal at the thing when you've been potentially newly diagnosed and you're committing to a new lifelong therapy, right? With potential complications down the road. Um, so even just starting medications and thinking about what does this mean for me? What are my hopes from taking this medication? Those are decisions that I talk to my patients about, on a daily basis in palliative care. Not necessarily starting carbidopa levodopa, but for my patients living with cancers, thinking about another line of therapy, thinking about more chemotherapy. Um, for patients living with neurological disease, I think a lot of what I talk about is thinking about what are the environments in which someone can feel both supported and safe, and also maximize their engagement and connection with their family. So for many of living with Parkinson's disease who do need more support in the home, do need more supervision, thinking how to make that happen in a way that honors what's important to people about their day-to-day life, brings them joy, is tricky, right? Because there's a financial component to it. And then there's also all the emotional aspects of potentially leaving home, a home that you hoped to grow old in. And then there's a caregiving aspect of it too. Caregivers often are so used to that role in providing the care that then thinking of relinquishing that or not that care, that can create all sorts of feelings about guilt or apprehension or anxiety about what that care might look like. So often with my patients, I'm talking about how do we piece together a solution that gets everyone's needs met, um, as much as we can. And I think the last group of big decisions that I really talk through with my patients and their families is thinking about their end of life and thinking about how they want to plan for that. Um, Talking about what they can expect or what are the signs that time is looking shorter. And in that time, how to make the best of it. Like, what's the best way that we should kind of tailor your care plan so that your needs are really being met during that precious and special time. So those are kind of just a few examples. Oh, Robin, I think you're muted.
I think when a lot of us hear end of life care decisions, red flags go up and we are start to get nervous.
Of
Can
course.
you say maybe at what point in your conversations with your patients, generally speaking, do end of life care conversations come in? I assume it's not on the first or the second visit with
Mm-hmm.
them.
So maybe I'll say something slightly controversial in saying that I think that thinking about end of life is in many ways, it kind of does start at the very beginning when I first get to know people. If only because for me as a provider, my philosophy is um that the end of life is a part of life, right? And so in kind of healthcare, we've isolated people who are at the end of life. We've shunted them away. We've put them away in hospitals or in different facilities, and so it feels like this thing that we don't understand and we can't know. And of course, natural kind of just human apprehension and fear about talking about the end of life. That is just the human reaction about thinking about mortality. Um, so there are a lot of reasons why sometimes it feels like end of life care is not something that we can really broach early on. And I don't, you're absolutely right, Robin. I don't explicitly, talk about people's end of life care plans necessarily when I'm first meeting them. It might not be what's important to them at that time. And that's much more important than, what's on my agenda. Um, but I do start at least getting to know people. I think that that is the most important thing I can do as their movement disorders neurologist when I'm meeting someone who's newly diagnosed. And I know that they live with this disease for decades. But in the very beginning, I think it's even important to just start talking about what is most important to you. What are the things you're worried about? What have you heard that you're might be fearful of? And what are the ways that, I can connect you to resources or provide you reassurance or provide you education about how we can confront those challenges and really hold up under the light the things that are really meaningful to you. And I think that that kind of conversation is something that I take a lot away from, but it's that is the primary joy of my work, right? Really holding people at the center of their care. And I think ne as a necessity, when one does practice that kind of person-centered care, when people do reach the end of life and time is looking shorter, in many ways, that trust has been developed. You have a sense of what's important to that person. And in many ways, the decisions that have to be made they'll feel like a natural part of the process because we've always been upholding those values all that time we've been taking care of them over all those decades. So I guess that's a long way of me saying that there's not a particular point in time that I think that people have to have certain discussions um, or about how to prepare the end of life. Um, but I do think that earlier on, we do need to have discussions about what to expect. How can we plan? How can we prepare? How can we support you? How can we get you connected to other people who are important to you and figure out and write down so that everyone just knows what is important to this person. Um,
Mhm.
yeah.
I would think that the question that you posed about what have you heard about, what are you fearful of? I would think that's a very powerful question that gets people thinking, and it certainly ties into, or could tie into what their hopes are between now and when
Mm-hmm.
the end
Yeah.
comes. Okay. Let's see what we don't have anybody have questions in the chat or in the Q&A box.
Yeah,
Otherwise,
I'm
I'll just,
checking Q&A. Yeah, looks like we've answered all of them for now.
yeah, okay. I'll just keep going down my questions then.
Yeah.
You mentioned about, wanting to be in an environment that feels safe. And what that led me to
Mhm.
believe was, or think about was, of course, facility placement, whether being in a care home or assisted living facility or skilled nursing
Mhm.
would be a better, a safer environment. Do
Mhm.
you sometimes then talk to families about whether facility placement would be the right thing?
Mhm. Yeah, that that the question of kind of long-term care planning is a huge part of my work as someone who interfaces with people with these chronic neurodegenerative conditions. Um, in Parkinson's disease and in many other neurological conditions, we expect that people's level of function and ability to do what they need to do to take care of this will fluctuate over time, will change over time. And so, for many people, not everyone, but for many people, the idea of potentially relocating to an environment where they have more support, more supervision can be it's a huge question. It's a big decision. It's a lot of time to process. It takes some
Mhm.
of my patients years to think that through for themselves. Um, and it's a complicated one because it has to do there are many things at play. Then people's, connection to their is a big one. It's kind of their emotional and existential kind of pride in the home that they've lived in for a long time is a very powerful force. It gives their life a lot of um s- solidity and meaning. And so that's something we have to weigh. I
Mm.
don't make this to leave home lightly, like at all, really. At the same time, when people start 24-hour supervision 7 days a week, the question of who's going to be providing that, right? Who's going to really be there to have a helping hand or an extra set of ears or extra set of eyes to make sure if that person ends up needing some sort of help or ends up falling, and needs another person there, like what's our setup? What's our plan for that situation? Some people can piece together the caregiving hours through different resources, either their own private financial resources or other kinds of federal or state resources. But it can be complicated for many reasons in that way.
Mhm.
And the other thing that I am also always listening for, especially when happen potentially a lot of changes for an individual, is really look out and ensure that their care partners are also being attended to. Make sure that they're not experiencing so much burden and potentially burning out. We know that the act of providing care for many years can have serious physical and mental consequences on people. So making sure that those care partners are also, getting some support if they need it is a big part of this question as well.
Yeah, one thing that strikes me in your talk and in the conversation we're having is that um, it kind of sounds like you have multiple patients. You have the person with a serious diagnosis, and then you also have the caregiver and perhaps additional family members who are part of the picture.
Mhm.
Um,
Mhm.
so how does Medicare or insurance who's paying for this, do they recognize
Mhm.
that you may have interactions with not with the patient, but with the family and with caregivers? Is that seen to be part of palliative care?
Absolutely. I think that palliative care in the clinic, so in the outpatient setting and also in the hospital it's in many ways a relational work that we do. So our specialty in many ways is about, yes, managing symptoms and all those other things, but also about community and relationship building and creating a safe space for people to make decisions together and even in situations where people may think differently about what's the right thing to do.
Mm.
At least so that's why from the very beginning when I first meet people in clinic, even if they sign on alone to the computer, I will ask them, like, who are the people in your lives? Tell me their names. How often do you see them? What's the relationship been like? How are they doing? Do you think they could need more support? So I like emphasize from the very beginning, even if I'm meeting someone alone, that talking about who those other people are in their lives is going to be a big part of what we do together. Um, from a decision making prospect, as a provider, kind of looking forward into the future, I also know that as people get sick, potentially acutely, potentially out of nowhere. The people who will actually be making medical decisions for that person may not be the person themselves when they are very ill.
Mm,
Um, Often when we're very ill, we're either confused or tired or just not to really process and receive information. And so, in many of those acute situations in the hospital or the emergency, there's a surrogate decision maker who needs to be identified, someone who knows that person, understands what's important to them, and then has to make big decisions for them.
mhm,
So, as a provider, myself thinking about this person as, yes, an individual, but also those people around them, I want to make sure, that if their surrogate decision maker is their sister, that there's what have they told their sister about what's going on?
mm,
What
mhm.
have they shared with them about um what may be down the line for them in the future? What have they do they kind of have the kind of relationship where he's been intimately connected to them and knows what so it's that the relational chess of things is very interesting and very important for my work.
Mhm.
So yes, so certainly including and talking to all the family members is incredibly important. In terms of
Yeah.
caregiving resources, essentially most palliative care teams will kind of offer caregiving resources and support to people who are not the patients themselves. So,
Mm.
of course, the patient is the person living with that illness, and we prize them. But if we find, the people around them resources, we will do that.
Yeah. So within your palliative care practice, since you're both a movement disorder specialist and a palliative care physician, um, are there things about your practice that are Parkinson's specific, or are there things about your, of course, many of your patients have Parkinson's disease, but are there
Mhm.
more of a generic palliative care thing, or is it palliative care plus
Mm, mm,
PD?
mm. So that's a good question. I think at this point in time, I kind of have this capacity to shift into different roles and wear different kinds of hats. So I do provide kind of generalist palliative care for people living with cancer who get referred to the palliative care clinic that way. And then I also have a special interest, right? So I'm a Parkinson's specialist to begin with. That was my home training. That's neurology residency. This is answering Susan's question. I did neurology residency. I did a movement disorders fellowship, so Parkinson's subspecialty training. And then I also did palliative care fellowship, so the kind of specialty training that palliative care doctors do. Um, so when I'm in the room with someone who has a neurological disease, and especially someone who has Parkinson's disease, um, I have a lot more of an understanding about kind of journey that that person took to get to that point in time. And I have a much more intricate understanding, obviously, about the Parkinson's medications. Um, all the kinds of titrations that people have tried in the past, all the kinds of side effects, if they've gotten deep brain stimulation, all of those things are, they're kind of like second nature to me because I have that background training. So I speak the language in many ways. And there are many things about Parkinson's, such as potential the cramp, the dystonia, the dyskinesia, all the different kinds of people run into that I have fluency with and the to understand immediately what could be leading to those kinds of experiences for that person. So often when wearing a palliative care hat, my neuropalliative care hat, and I'm seeing someone with Parkinson's disease, I can kind of function at that time both. I can kind of act with the kind of specialty focus of their movement neurology and be able to, well, is this normal? is this I should be expecting to feel or to see? Or is this going to happen again? I can answer that because I have that kind of expertise about Parkinson's, since those are most of the people that I've ever taken care of. Um,
Yeah, that
and
that combination to me would seem to be very powerful, that you're very
yeah,
familiar with the medications, with the side effects, uh, you're very familiar with the symptomatology, and so
mhm,
you're well placed to provide excellent care to patients and their families. So just because of that,
yeah.
so that's great. We have one other last question we'll have is our resident social worker expert says, I realize that we're focusing on the subject of palliative care, but I'm curious as to what the training is like for a physician entering this subspecialty.
Mm, that's a great question, Susan. So I'm going to interpret that question. I suppose you can correct me. Um, as a neurologist or movement disorders neurologist into palliative care, what that getting additional training in palliative care was potentially like. So, from a professional standpoint, the thing that maybe I think the way of even answering this question is having done extra training in both, having done my palliative care training after Parkinson's training, and then coming back to being a Parkinson's doctor again, is just realizing how much better of a movement disorders neurologist I am. I think that has been the most powerful professional um, aspect of having completed the training like I did. Um, Essentially, I think the things that, I sometimes struggled with as a movement disorders neurologist is not feeling like I could make time and space for people's big questions, and not feeling like I had the skills necessary to support emotions if they arose in the visit, and feeling kind of helpless at times to talk about really, really hard things. Um, Doing palliative care training, taking on that kind of mindset and philosophy of care has given me valuable skill set in being a better doctor in the way that's important to me. So that has been an incredibly powerful and meaningful aspect of doing my training way. Also, doing my training this way revealed to me so many people living with Parkinson's disease or neurological disease who aren't able to access a neurologist anymore, right?
Mm-hmm.
They either have just really not able to make it into clinic, because there's so many other things going on, or if for any number of reasons, there's so many people living with neurological disease who are really, aren't that you're not seeing as a neurologist more. You're not necessarily titrating medication on and off all the time or changing doses, but there's still so many big things going on. And I just feel like I have the wonderful, privilege of having seen both sides of it now as someone who is a neurologist and then stepped outside of it for a little while.
Yeah, great. We get two more questions came in, so let me ask them. Would you consider taking a patient with ALS, or does the ALS clinic have a relationship with palliative care?
So, yes, in my neuropalliative clinic, I see people living with ALS as well. Essentially, the neuropalliative clinic will take on anyone who has a neurological diagnosis. So, absolutely, we see people living with ALS in the palliative clinic, myself and the other palliative care doctors.
Okay. And your slide said Stanford Palliative Care is available for anyone in the Stanford system. I'm newly diagnosed with young onset Parkinson's disease via my neurologist at PAMF.
Mm,
Do I need a referral to a Stanford neurologist or movement disorder specialist first to access your particular clinic at
mm.
Stanford Palliative Care?
So to access my specific clinic, the best way to do that would be to ask your neurologist to place a referral to Stanford Palliative Care. We certainly take referrals from outside the Stanford system, the palliative care team. So it would be possible to access my clinic specifically in that fashion. However, I also the Infant Center has a really robust palliative care team too. So because they are in your system, because they get records, because they probably know your neurologist or have worked together with them and they have that professional collaboration. My advice would be maybe see how things go when you meet them first. You might really like them. So they might really be able to meet the needs and answer the questions that you have. So you can always start there. And if you feel like, well, I'm not getting the traction that I was hoping for. I really would like to have that neuropalliative care, that super niche focus, to have my questions answered. Then asking your PAMF neurologist for a referral to Stanford Palliative Care, designating the desired see neuropalliative care would be the way to do it.
Yeah. Okay, great. All right, well, we'll wrap it up there. There were a few other specific questions, and I can follow up with folks later. And Dr. Jiao has graciously made her slides available to us. So that plus our recording from our talk today will be posted to our website in a couple of days, and probably by next Monday or Tuesday. And a Happy New Year again to everyone, and thanks again, Dr. Jiao.
Thank you all for having me. Have a lovely day.
You too. Bye bye.
Bye.